on the webinar today, we've got two people presenting. Dr. David Gastrin, who's the Chief Architect of Continuum. He's actually spent more than 2 decades of research and work to make Continuum possible. And then you've got me, Brendan McEntee. I'm the Director of Quality and Science with the American Society of Addiction Medicine. ASAM is the leading specialty organization of addiction clinicians. Our goal is to help addiction clinicians do their job well, so we provide education, research, clinical guidelines and criteria like the ASAM criteria and Continuum, and we advocate for the profession. ASAM itself provides the clinical oversight and endorsement to Continuum, so you know that the decision rules and the answers that you're getting from Continuum are actually what is outlined by the ASAM criteria, which is used in over 30 states. If you have any interest about learning more about joining ASAM or what we do, please feel free to reach out to me. My information is there on the screen. And with that, I'll pass it over to David Gastrin to get us started.
Great. Thanks very much, Brendan. I'm very happy that so many of you could be on this call. There are many dozens of you out there listening in, and we will have time for questions. In fact, you should feel free to type in your questions as we go along, and I will look at them and be glad to answer. The first thing I want to point out is that Continuum is a computer-assisted structured interview followed by a decision algorithm that precisely and quantitatively calculates the ASAM level of care for the patient's treatment recommendations. It gives you the DSM-5 substance use disorders, both the diagnoses, and it calculates through the criteria. It tells you how many of the criteria are present. It gives you the withdrawal scores for alcohol and sedatives and also for opioids using the CEWA, AR, and the CENA instruments. I'll show you a little bit about these when we do the tour. The Addiction Severity Index is entirely present, the 5th edition, and it calculates the full composite score for all 7 ASI dimensions. It calculates imminent risk considerations for acute psychosis risks, for suicidality and danger to others. It also determines access issues, support needs, and patient capabilities and resources. Finally, the algorithm calculates the ASAM level of care, and it considers all adult admission levels and sublevels, including withdrawal management levels, the biomedically enhanced sublevel, and the co-occurring sublevels for capable and enhanced care. And it generates a report, which you see here, that's suitable for PDF storage in your EHR or printing. Actually, it generates a second report, which is the full listing of all the questions that your particular patient was asked and the answers. And that also can be stored as a PDF in your EHR record or printed out and put into the chart. A very important and unusual feature that doesn't exist to our knowledge in other systems is that if the patient gets placed in a different level of care than the software recommended, not only does Continuum accept that, but it gives the clinician the opportunity to justify the reason for the discrepancy. So if the patient is not going to the recommended level of care and it's because insurance won't cover it, we track that, and we can actually look at the frequency of those events, hotspots, potentially look at regions where geographic access isn't available, programs that reject the patient, whether the patient rejects the program. These are all reasons for the discrepancy. This approach has been studied using this software or its predecessor for about 20 years. MGH, Massachusetts General Hospital, and Harvard Medical School conducted a study using the software that led to Continuum with NIDA funding. The first study was 3 cities in Massachusetts looking at level 2 versus level 3. That's intensive outpatient versus residential care. after the patient completed detox. And this had 700 patients in it, and the computer assessed the patients, calculated the recommended level of care, but kept that blind. So neither the patient nor the research assistant nor the treatment program knew what level of care was actually recommended. And half the time, it actually sent the patient to a mismatched level of care. And here are the results from that mismatch. If you look at the overall population, 700 patients, undermatched patients, patients who got less level of care than the software said they really needed, they had a 25% worse no-show rate to that next level of care. If they had cocaine high-frequency use, there were 183 of these patients. The undermatched patients had 100% worse no-show rate to treatment. In patients who used heroin, 279 patients, the undermatched patients had a no-show rate 300% worse than the matched patients. So these figures are not just significant. In fact, they're highly significant, 0.001. But these are dramatically worse no-show rates into the next level of care. Here's a different study. This doesn't look at immediate no-show rates, but rather 1 year hospital utilization outcomes. And this was also conducted by my group at Massachusetts General Hospital and Harvard. And this was a study in the Bedford, Massachusetts VA, which only provided one level of care. So it was literally a one-size-fits-all. It was a level 3 residential program. If the patient needed day treatment or partial hospital, they were overmatched. If they needed hospital, they were undermatched. And what this study did was look at 1 year outcomes, but they compared the previous period of time and annualized that previous use of hospital bed days. And then after the placement, which is sort of this break between these blue and red bars, then it looked at what about the next period of time, the next year of follow-up. And you see that if patients had adequate matching, they went from the previous year down in their hospital bed day utilization over the next year. If they were properly matched, they went down and went down more. But if they were improperly matched, that is undermatched, and they needed hospital care level 4, but they only got residential because that's all the medical center provided, their use of hospital bed days went up and substantially and significantly over the next year. Let's look at one more study before we leave the research. And this is done in Norway. The Norwegian Health Trust, which is the government, funded a study across 10 treatment centers in Norway, 261 patients. They received a research assistant baseline interview and 3-month follow-up. And they were naturalistically placed by counselors who didn't know what the computer recommended. And so this was a naturalistic but blind placement. And then they looked at their outcomes. And there are 3 ways to look at these outcomes. First is, what % dropped out at 3 months? And what they found was that matched patients had 30% better completion rates in a treatment if they were matched than if they were undermatched. So this is actually a big difference. It's not just significant. What about the number of addiction severity index subscales that improved? There are 7 of these subscales. And the people who were matched improved on 6 out of 7 subscales after 3 months of treatment. But the people who were undermatched only improved on 2. So this is a 3-fold advantage of matching. And even the people who were overmatched didn't have as good outcomes on the ASI. Another way to look at it is step down. What % were ready for step down at the 3-month follow-up? That is, they didn't need as intensive a level of care anymore. And the answer is a much higher percentage of patients who were properly matched were ready for step down, according to the software. So this is several different outcomes, several different time frames, different populations, different kinds of insurance and healthcare structure. And you can see a very consistent pattern, and there are many more studies than what I've shown you. Let me show you what Continuum actually looks like. And I could take you through slides, but I think it would be interesting to actually show you the software itself. So let me show my screen. Brendan, are you seeing the screen now?
Yes, I am.
Good. All right. So this is actually your computer logging into the internet to the server for GoToMeeting, which takes you to my computer, and my computer is going through the internet to the FEI computer, which is the company that is ASAM's tech partner, and you're seeing their server over a double trip through the internet, which is pretty cool. So, let's all give thanks to the speed of light. Anyway, on the left side of the screen, you see what we call the navigation window. And the navigation window or panel allows you to see the sequence of questions that will be asked, and it goes in a logical sequence that's designed to make it easy to process the engagement of the patient with the clinician. So the clinician has time to go through less emotionally laden, less provocative questions and proceed through medical history, employment history, before getting to the more stigmatizing and provocative questions like drug and alcohol. So there's time for the rapport to be developed and for the helping alliance to be established before the patient gets into the more painful and sensitive stuff. And family and social is even more tricky sometimes because we get into abuse questions, and psychological can be the most stigmatizing if the patient thinks that they have a substance problem. So we go through this sequence if that is comfortable for the patient. But what if the patient says, well, I'm here because my probation officer told me to be here, and I got to tell you about my legal stuff. Well, then we can use the navigation panel to jump to legal information and quickly enter the information that the patient wants to tell us. And then we can go back because we might see that, oh, we don't have this green check mark on medical history, so that means it's not finished. So we can come back and finish medical history and employment and so forth. So the navigation window allows us to jump around and be very flexible, which is quite different from a typical research interview. So that's one way in which Continuum is really a clinical interview, not a research interview. On the other hand, the questions that it asks are research quality questions. Many of them are directly from research instruments, or they're constructed with the precision and reliability of research instruments. So you'll see here in the right side the window which we call the interview panel. In this interview pane or window has some questions that have an icon of two people, and the question is in quotes and italics. So this is an interview question, and we're going to ask the question verbatim. And we can paraphrase it, however, to suit the patient's level of comprehension. And that flexibility is also part of a clinical interview, and it's a little different from what research interviews often require. So this is an advantage in clinical care. So when was your last use of alcohol? We go through recency and quantity, frequency questions, and then we get to some more sophisticated stuff. Now, in the assessment of withdrawal, there are some good research quality instruments, but they require training and retraining, and you have to test the reliability. You have to determine if the patient has a problem on a quantitative scale that you have to memorize, and often that's just not as good for clinicians. So what we do is we translate each of the numerical ratings into an English language anchor phrase. So let me show you how that works. Here we are in the CINA, the Narcotic Assessment Withdrawal Scale, and you see a question that has not two people in the icon, but one person in the icon, and it's not in quotes and it's not in italics. So this is not a question that is asked verbatim to the patient, it's an observation. And the observation is asking the counselor to rate tremor. Well, how do I do that? Well, have the patient's arms extended and fingers spread apart. All right, so stick out your arms for me, would you please? And spread your fingers apart. Okay. Now we're supposed to make an observation. Now this is not a nurse. This is not a physician. How are we going to rate tremor? Well, is there no tremor? Or is there no tremor visible, but it can be felt fingertip to fingertip. Okay, so I'll put my fingertips to touch your fingertips, and wow, I feel some kind of little tremor in there, even though I don't really see it. Or is there moderate tremor when the patient's arms are extended and clearly the patient's hands are shaking? Or is it severe tremor, where even with the arms not extended and relaxed at the patient's sides, they're jumping up and down? So this allows the clinician, without nursing or medical training, to make a research quality assessment of a physical sign. And the computer regards this as a 0, 1, 2, or 3. So it's fully quantitative, and it's precise. It's hard to make a mistake if you're reading these thoughtfully, because they're so clearly laid out. And that's one of the ways in which this clinical interview can obtain reliable and research quality information. Another feature of this, and I won't go through everything here, but I'd like you to appreciate some of the sophistication that went into the design of this program. Counting the times in your life you have been treated for alcohol use, how many of these were withdrawal management only? Now, typically, we will ask how many times you've been treated, and the patient might say, oh, 10 times. Except if we tell managed care the patient's been treated 10 times and we want to admit the patient to rehab and detox, they might say, well, look, you know, an 11th time doesn't sound like it's going to make much of a difference. Why don't you, they might say, why don't you have the patient in outpatient treatment for 3 months and do motivational enhancement work with them, and then call us back if they really are ready for detox and rehab. And that might be the wrong answer, because if we go into how many times were for withdrawal management, and the patient might say, oh, they were all for withdrawal management. Well, have you usually left withdrawal management before you were advised to in the past? The patient might say, yeah, actually, I never really went through the next step because I didn't think they gave me enough meds before. And after withdrawal management, have you usually entered continued treatment? And the patient might say, well, no, you know, because I didn't think I wasn't really ready. And now I'm really ready to stick through. You know, I'm kind of burnt out, and, you know, my girlfriend's leaving me, and I won't have a place to stay, and I realize I've screwed everything up. I can't get money from my mother anymore. So I feel like I got to go through the whole big, you know, the whole big deal. So if we called managed care now with this information, we might be able to say, look, this patient has had 10 or whatever detoxes before. We don't want to do a revolving door of an 11th detox. Now the patient is ready for rehab, and we don't want to miss this window of opportunity. And then managed care might say, well, you know, all right, you got it, 10 days, call us back and let us know how the patient's doing. So it can make a big difference. And additional essential things are craving. Craving is a question in the DSM-5, but we often don't get good, in-depth, operationalized meaning in a craving question. So the patient sitting in your office is going to be stuck there for a couple hours, isn't thinking about you know, any access to drugs for the next so long, and their amygdala isn't scanning the environment to hunt for drugs. So they're going to say, no, I'm not craving. And that might be the wrong answer. But if you say, imagine yourself in the environment in which you previously used drugs or alcohol. If you were living in this environment today, what's the likelihood that you would use? And the patient might say, well, of course I'm going to use. There's no question about it. So now we have this colored scale. It's not just numerical, and it's not just with English phrases, but the green is the safe, the go-ahead, the least concerning answer. Amber is in the middle, and red is the danger or most serious answer. And Continuum uses this color scheme for all numerically rated items so that it remains as intuitive as possible. So this craving question is operationalized several ways. The next one is rate how strong your urges are for a drug when something in the environment reminds you of it. So now we're looking at cue response. And how strong is your desire to use any drug right now? Well, now we have cued the patient into thinking about this. So now they can answer whether they have craving right now. Another one is the trajectory of symptoms. So have your addiction symptoms increased recently? Now, if you work with patients, you know the typical answer might be, yeah. And that might be all the patient says. And it's partly denial and partly lack of understanding of the complexity of these parameters. So the counselor is prompted to ask, well, how? How has it increased recently? And the patient might say, well, I can just tell it's really gotten worse. And again, that could be denial. It could be just limited perception. So we have to ask about any items below not mentioned by the patient. Well, have you had more craving? Oh, yeah, my craving is getting worse and worse. It used to be just after the weekend when I used, but now it's all week long. How about risk behaviors? Well, I don't know if this is what you mean, the patient might say, but I'm going to those bars where I used to get robbed or beaten up before, and I probably, I'm not being very smart doing that. How about more frequent use? And the patient might say, well, I used to use just on the weekends, but now I'm using every day. How about increased amount of your substance? I've had patients say, well, I used to drink beer, but now I find that's not holding me, and I've switched to whiskey. Or have you used a more rapid route of administration? And I've had prescription opioid patients say, I've switched to, using heroin my boyfriend started giving me, and I'm really worried about that. So we've gotten a lot of these components operationalized in a way that the patient can understand. We've asked a sequence of items, and we've asked it in terms of the time course. So now, how do we have the counselor rate this? Is it a no? Is it increased thoughts or craving without use? Is it more risk-taking behaviors but not use? Like, is the patient going to the old neighborhood where they used to buy their drugs but not yet buying it? Has the patient relapsed but to less use than when using before? Or is the patient showing increased use or more acute route of administration than before? And each of these is clearly and discretely different from the others, so it's very easy to get precise and reliable measurement, but yet it's English language. It's the information that's clinical. Meanwhile, the computer scores this as a 0, 1, 2, 3, or 4, and that's how the algorithm puts the answer into the algebra of the level of care decision. So there are a lot of complex ideas that are operationalized and scored in this fashion. For instance, motivation. Do you have any concerns about pursuing treatment? No, I know, I need to do treatment. Well, would anything possibly hold you back, such as money? And the patient might say, oh, no, I can't spend money, I don't have any money. How about insurance? Well, they're putting me on leave from work. I don't know if I have my insurance. I can't let the work people know what I'm doing with my treatment if I'm going. I don't want to use my insurance. How about schedule? Well, if I'm going to try and get day work, and I don't want to be tied up during the day. How about attending groups? Oh, no, I'm shy. I don't share my business with other people. How about having to take medicines? And I've literally had a patient say to me, no, doc, I'm all natural. This was a drug addict. How about drug tests? Well, wait a minute, I came here voluntary. If you're going to drug test me, it means you don't trust me, and why should I trust you? And how about drinking or drug-using friends? And the patient might say, well, what do you mean? All my friends are drug-using. Well, what do you want me to do, get new friends? So is this patient fully participating in recommended treatments already? No. Is the patient open to participating in any recommended treatments? Clearly not. Is the patient passive or having some hesitations? Yeah, but it's worse than that. Is the patient resisting important components? Yes, definitely, but it's maybe worse than that. Or is the patient rejecting or obstructing the plan with many contingencies? Well, this is clearly the right answer. So we have, again, a full range of operationalized considerations, but they're each discrete from one another, and that provides a lot of specificity and precision and quantitative detail. Again, how do you plan to prevent relapses? Many different ways to ask this question, many different options for answering. So we can get through complex constructs, motivation, trajectory, craving. We can get through complicated, emotionally laden issues such as abuse. After assessing the drug history and the legal problems, we get into the family and social history, and it sequences even the novice counselor to do a proper abuse assessment. So after, are you satisfied with these relationships, unsatisfied with these relationships, and so forth? It then asks, well, have you been emotionally abused in the past 30 days? And a more emotionally laden question is physical abuse. So it waits to do that question second. Have you been physically abused? And the most emotionally laden question is, have you been sexually abused? So this sequence allows the patient to see that these are questions that will be posed. The clinician will have a non-judgmental reaction to whatever the patient says, and therefore the patient is more inclined to give a meaningful answer. Then it asks a really important question, which is hard to ask. This is the abuse question towards others. So it asks, have you recently neglected or abused family members? And the reason it poses the question with that precise wording is because there are individuals who are actively abusing others, but they will not admit to that word. But they might respond to the neglect word. So they might, the patient might say, well, my wife thinks, she thinks I neglect her, she blames it on the booze, but, I think, it's just not working out that well between us. So here's a patient who is now able to give us a cue to come back in the post-assessment session, schedule a family member visit, and explore the issue of neglect or abuse in depth. Another area that is thoroughly explored is the psychological history and condition of the patient. And it goes through a psychological symptom inventory that's quite broad. It covers a lot of the different disease states. And it does it in the following way. It asks, have you had a significant period in which you experienced serious depression, the blues, or hopelessness in your lifetime? And the patient might say, oh yeah, I've been really bad. And then it'll open up because it's a branching interview. So the screens are constantly changing depending on what the patient's answers are. And that's good because it makes the interview feel quite individualized for each given patient. And the clinician who's doing assessment after assessment is going to feel that every interview is different, as it should be. So now it's asking, how about in the last month? And the patient might say, well, it's not as bad as the worst time I've been depressed, but it's pretty bad. Would you say moderately? Yes, that's a good way. Okay, I would say moderately. How about in the last 24 hours? Yeah, it's still that way. It's been that way the whole month. Okay. And now it poses the question, and this is, again, a dialogue question. So we ask the patient, was this problem within the last 24 hours related to using drugs or alcohol? And the patient might say, well, I get this way when I drink. It's especially bad, like the day after I've been drinking heavy with a binge. I can pretty much predict it. So it's not unrelated to use. It's not likely related to active use or intoxication. It's likely related to substance withdrawal. So that's how we would answer this question. And each of these symptoms gets related, if it's current, if it's in the last 24 hours, each of these symptoms gets related to drug or alcohol use in that same fashion, so that we can build a constellation of problems and their relationship to substance use or withdrawal. Now it goes through flashbacks, cognitive problems, irritability, access to stuff, violence, urges to hurt or destroy property, trouble with relationships, and then it goes through a suicide assessment. This is an important feature, and it's not common in clinical work. Often programs will tell their clinicians, if the patient's suicidal, we don't do that kind of work, refer them out to the crisis unit. And that could be the wrong answer, because maybe the program can treat the patient. So it structures the clinician, even the novice clinician, they could be on their first day of the job, and they can still do this assessment and do it right. I happen to know this because I was a resident in psychiatry starting my very first day back, I think, in 1980 at Massachusetts General Hospital in the ER, which is one of the preeminent ERs in the country. And here I was, this kid who, come out of medical school and an internship, and I didn't know what I was doing. And they said, don't worry about it. Here's a laminated card with the questions you should ask. And I had it in my pocket, and these were the questions. Have you had serious thoughts of suicide, that you'd be better off dead or wanting to hurt yourself? So that's suicidal ideation that we're now assessing. Have you had thoughts of how you might hurt yourself? So that's suicidal plan. Have you had any attempted suicide episodes in your lifetime? And that's history of gesture. And later it'll assess ability to access resources and capacity for contracting and the availability of others close to the patient who can monitor the patient's state. So that all gets calculated into a careful suicide evaluation, and it can determine, especially in relationship to substance use, which it does, whether stabilizing substance use might stabilize the suicidality risk. So these are just some of the features, and I will stop there. I guess I should show you the report, because you're probably interested in what this ends up looking like. So in the report, we get a paper printout or a PDF that can go right into the chart or into the EHR, and it will print out just scroll it down, several sections. First, probability of psychiatric or psychological conditions. It doesn't do an actual psychiatric diagnosis. That actually takes a much more involved structured interview and is better left to mental health professionals. But it'll indicate the likelihood of a psychological condition. Then it goes through the DSM-5 diagnoses and the number of criteria. It says here drug, alcohol dependence, severe with 10 criteria out of 11 met, last use 1 day ago, imminent withdrawal considerations. And this is provided to you with licensing from the APA, from the DSM Commission. So it's the official process. Then it goes through the withdrawal status of the patient, and it'll actually give you the score, 16 on a scale of 0 to 67, and then it puts that in perspective. Patients with a score of greater than 15 are at increased risk of withdrawal, and that will be taken into account in the placement. Same thing for the narcotic scale. The next material in the report is the ASI, and it provides the ASI composite scores both in a table with the precise numbers and in a graph. And so you can quickly see, well, alcohol is the big problem, but this patient has some psychiatric stuff that's notable as well. And then it'll provide critical items, in this case, potential harm to self or others. If it had acute psychosis or something else that was acute, that would be in there too. It then provides a dimension-by-dimension consideration of what levels of care could work for each or be needed for each particular dimension. And this isn't essential when you start out, but after you get sophisticated with it and you want to go into the depth of how does it reach its determination, you get the benefit of having all this information. And it even does it in a table. And remember, ACE is not a research instrument. It doesn't do sort of an average or a mean or dimensional scoring. Instead, it does a decision tree type of scoring, just like expert clinicians use. So it's not just you add up the number of plus signs and you find out what level of care the patient gets. That would be very cookbook, and it doesn't really follow the complexity of addiction problems across ASAM's 6 dimensions. So you still need to consider things like access to treatment. Now, this patient does not have continuous monitoring available at home. This patient isn't reliable with self-care. This patient isn't able to self-administer medications compliantly. So if we have all that information, and there are multiple questions that get at each of these issues, then we're really in a position to do the final level of care placement. So here's an issue that distinguishes Continuum, again, from a research tool. A research tool would have to give a single quantitative recommendation, and that would be black and white. But in the real world, clinically, that's not necessarily as useful. So Continuum can say, it doesn't necessarily say this, but it can say, consider multiple levels of care. In this case, it could be a combination of 2.5, partial hospital, and 3.1, the lowest intensity of residential monitoring. And if that's going to be the case, the 2.5 needs to be co-occurring enhanced for mental disorders. Or the patient is best initially treated in level 3.7, which is the highest level of residential care. And if that's going to be the case, the patient needs a co-occurring capable program. Notice that if the patient gets this higher intensity of residential, they don't need the enhanced co-occurring, and a co-occurring capable will be adequate. So it's really nuanced to the particular recommendation. And finally, the patient does have some criteria that partially meet the need for opioid treatment services, and this could be methadone, buprenorphine, or extended-release naltrexone, but has not met the final level criteria for opioid treatment services. So if managed care sees this report, and you can fax this report to managed care, and in the many, many states that require ASAM, this is the definitive ASAM recommendation. And so managed care could say, well, we think that level 2.5 and 3.1 will be less expensive, and so we'd prefer you send the patient there. That's what we want to approve. But if you don't have it available, then you are equipped to effectively argue, no, we don't have that option available. It has to be 3.7. And it's very hard for managed care to dispute that then. So this is how programs, and there were 20 systems across the country, some of them were multi-level, multi-facility systems, that used Continuum for a 6-month period last year. And they told us that it consistently sped up the utilization review process, and it was much more likely to get approval of prior authorization than the typical back and forth argument process. So that's the lay of the land with Continuum. And let me take you back now to your screen, if I can find it.
And I can take back that, David, and bring us up to the next section. Thank you so much for that great presentation.
Okay.
Just pull that up.
Great.
So now we're going to go into how you can actually get Continuum for your system. Start by saying that Continuum is not your typical early 2000s era software that might be in a CD. It's actually, there's no individual product or CD. It's only available for purchase through integration with an electronic health record, practice management, and/or billing software. And that's because Continuum actually lives in the cloud. The software is up there, and you're accessing it through your computer. And you're able to actually pull it into the EHR and interact with the online software. There's a couple of great advantages with that. One is that you always have access to the most up-to-date version of the software. You never have to worry about updating the version. You're always getting whatever changes ASAM has put into it. And David, I think I'm getting a little bit of feedback. Would you mind placing yourself on mute? Thank you. Additionally, all your data is secure, so if your computer happened to break, you'd be able to actually get the data back in the system. It's stored online in servers that are both HIPAA and 42 CFR compliant. So then the question comes, how do you actually get Continuum out of the cloud? And there's a couple different scenarios that you might fall into. In the first scenario, your company might actually have a commercial EHR. In that case, you'd want to ask the company that provides the EHR to your company if they can integrate Continuum into your system. On the Continuum website, www.asamcontinuum.org, you're able to go in there, and there's information for the EHR vendors about how they can integrate Continuum. Or you could have them email asamcriteria@asam.org. In the second scenario, your company might have your own proprietary or homegrown EHR that you've actually created. In that case, they could speak to ASAM directly, and we could work with them to integrate Continuum into your system. In the third case, your company might not actually have an electronic health record. In that case, you'd actually have to purchase a system that offers Continuum. And once you had that, you'd be able to get Continuum. There's a listing of those companies online at www.asamcontinuum.org/sales. In any case, you want to make sure that the company that's providing you Continuum is an authorized Continuum distributor. That'll ensure that you have the product that is endorsed by ASAM and that is giving you an accurate level of care assessment. ASAM is actually working with over 20 different electronic health record companies right now to integrate Continuum into their system. You can see the first one, CompuLink, on our website, asamcontinuum.org/sales. And I also wanted to point out that Behavioral Health Care, who does a survey of electronic health record vendors every year for what sort of services they offer in their platforms, added into their 2015 survey whether or not the companies would be offering Continuum. And that sort of goes with what we're experiencing. 20 of the companies that they surveyed said they would be working to get Continuum into their system. If any of you are looking for your EHR to have the product integrated and you're wanting some sort of help and guidance in that, you can feel free to reach out to ASAM about that. I'll have the email address up in the last slide that you can email out to get some assistance with that, or if you want to put into the questions box your name, the name of your company, and the name of your EHR, I'd be happy to store that information and contact you directly. So how much does Continuum cost? Once it's actually integrated into an EHR, you can purchase it for $70 per user per month. And that gives you unlimited assessments with everything that David sort of covered in that first portion of the webinar. The great thing is that really the only people that need access to Continuum and that you're going to be charged a $70 per user per month fee are those people who are actually going in and conducting the assessment. The final printout report that David showed gets pulled back into your EHR, and anyone, regardless of whether or not they have access to the Continuum software, will be able to pull that from your EHR's platform without paying that $70 per user per month fee. So now we'll head over into the question and answers section. As a reminder, if you have any questions, you can put them into the GoToWebinar control panel box, and we'll be reviewing those and answering those. You can also go to Continuum, asamcontinuum.org. We've got a knowledge base online. There's webinars. We'll be uploading this webinar to the knowledge base, and there's frequently asked questions, and there are training videos. Or you can email a question to asamcriteria.org. I see that we've got several questions in already, so I'll say the first one to David. We had a few people asking whether or not the Continuum assessment could work for adolescents.
Sure. Are you hearing me okay now?
Yes, thank you.
Good. So Continuum has been developed for adults. And while the book, the ASAM Criteria, which is the companion to the software, has numerous sections that adapt the decision logic for adolescents. That has not been implemented in this version of the software. So if you're going to use it for adolescents, here's what I would recommend. I would use it as is for anyone, 21 and older adults. Theoretically, it should work well for 18-year-olds as well, and 19-year-olds and 20. Below that, I think you have to have you have to use a grain of salt, both in the questions. There may be questions that need to be phrased differently, and you should feel free to do that. And the answers you may feel may not completely pertain, and the recommendations. You may have to reinterpret the recommendations. So, as a fundamental outline for gathering data and the operationalization, I think you may find it quite useful, and programs that used it in the national demo did find it useful, but you should not feel the need to adhere to it as closely with adolescents.
Thank you, David. We also had a question about who can use Continuum. Is there training needed, and what level professionals should be doing that?
In the national demo, we allowed programs to use Continuum with any clinicians they chose. They had expert clinicians, people with doctoral and master's degrees, but they also had people with bachelor's and with no degrees using it. In fact, one program even had probation officers using it who didn't have much addiction expertise per se. We will be developing training to assist you. There is online training where you can actually see a mock interview that I conduct start to finish to get the feel and the basics of how to go about it. Most programs told us it was very easy to adapt to, and within 5 or 10 patient interviews, they were going smoothly, and they got the speed up and felt quite comfortable with it. It does not require any kind of certification or licensure, but it is important to understand the ASAM criteria. So there are other sources, webinars and trainings, video trainings, about the ASAM criteria and what are the levels of care and what are the dimensions of assessment, because you do want people to understand the whole theory and practice of the ASAM criteria book.
Thank you, David. And you discussed this a little bit, but we had a question about how the generated report can be used for utilization reviews, and perhaps you can mention a little bit about how that functioned in the demonstration phase that we did.
Yeah. So, utilization review typically is done by telephone with a nurse reviewer on the other side working on behalf of the insurance company. And typically, you got to present the case to them, and they say, oh, you didn't find out these things, go back and find out more from the patient and call us back, and then you're involved in this telephone tag. And Harvard Business School did a case study over the course of a year with Continuum and found that this conventional back and forth with prior authorization could take 3 hours to 3 days, and patient dropout was not uncommon while patients anxiously awaited if they would even get covered for this care. So with Continuum, what programs find is they either call the managed care company, and in the presentation they say, and we use the ASAM software Continuum. If they're in an ASAM state, and there are about 35 of them, they say, and we are in ASAM state, so even if the insurer is out of state, they have to comply. And this is the official endorsed ASAM level of care recommendation, residential or whatever it is. If the treatment program gets a denial, they can say, well, I want an appeal. Often, the medical director to whom the insurance company escalates this review is a member of ASAM. And so when they get on the phone or when they review with the nurse clinician and they hear, oh my God, they used the Continuum already, they got the official ASAM recommendation, well, they're in an ASAM state, we can't dispute that, so go ahead and overturn the denial. So that's how it works. Now, it may work even better to just fax the 5-page report to the insurer, and programs have done that. We're going to explore with insurers actually having electronic transmission of the recommendations directly to the insurers. That's not set up yet. But eventually, when you're actively using Continuum, we hope to get you to a point where, just like when you swipe your credit card at the supermarket when you want to pay for your groceries, and the bank gives an immediate, instant authorization for payment, we're hoping to be able to set that up with insurers to give an instant authorization for reimbursement. There's no reason the technology can't do that. So Continuum has been designed to get to that place.
Thank you, David. And I just uploaded a flyer to the handout section of the GoToMeeting that has some of that information as well. We have another question. It is, what is the average time it takes to complete the interview with Continuum? And can certain pieces be turned off or on and still provide a valid placement recommendation?
Yeah, that's a great question. So programs that used it in their conventional routine assessments found that they started, and it could take 2 hours to do the first assessment, reading through and seeing the branching and figuring it out. Once they'd gone through 5 to 10 cases and got through the learning curve, they found it was taking 60 to 90 minutes. But remember, they were reporting that it so sped up the managed care interaction that the vast majority of them said that they loved it and would like to continue using it beyond the demonstration phase. So it really puts a little bit more effort up front, but then gives you a much better speed and follow-through and successful outcome on the downside, on the far side. So you're sort of putting more of the effort up front and getting more return in the end. We found that programs that wanted to admit patients, let's say, to detox, where they didn't have either the patient cognitive function or patience to sit through an hour-long or 90-minute interview, they just started with the medical tab and the alcohol drug tab. They just did those two sections, which they, as I showed you before, they could easily navigate through in the navigation panel. And when they did that, they got enough detail to justify an admission, and that report back and forth with managed care went very smoothly. It doesn't generate a level of care recommendation at that point. So then what they did was, a few days later, when the patient was stabilized in detox, they completed the rest of the interview, and then they used that level of care recommendation to guide the step down or follow through to rehab. The other thing that I should mention is that Los Angeles County, which looks like it's the first customer for Continuum, the County Department of Public Health, has asked ASAM to create a teletriage tool, a 20-question telephone interview that can rapidly determine the most likely place that the patient should go, so that they can guide the patient to go to that level of care and get their full continuum assessment. And so that has all been drafted up and is in the process of being implemented in software. So that'll be a derivative product that will be available, I don't know, it might be 6 months down the line now.
Thank you, David. This question is somewhat similar to asking about how you can use Continuum in reassessments, and perhaps you could talk a little bit about how you can compare the data from reassessments as well.
Yes. So we designed Continuum for reassessment, and you go back, whether it's 5 days later, or 10 days later, 30 days later, or if it's an outpatient, maybe 3 months later, and you press a button to clone the previous report. And what it does is it opens up a new patient assessment, but the new patient assessment is filled with the data from the previous assessment. So it's a new interview, but all the previous data are there. And so you go through the items now that are likely to have changed and update them. So it should be a faster interview. It should be an informed interview because you're reminded of where the patient was at the previous assessment. And then when you score and save that, now you have a follow-up interview. And that's exactly what we did in the studies. So when I showed you the Norway study, for example, that's what we did. And we looked at the change, let's say in ASI scores, or the change in withdrawal scores, if you're looking at the end of detox, or the change in motivation or risks. And you can also look at the change in level of care recommendation to see whether the patient has progressed to be able to step down. If your program is Joint Commission or CARF accredited or has some kind of licensing or contracting obligations, this is a superb mechanism for evaluating the overall success of the program, because now you can show precise quantitative change in every single patient. And you didn't do extra work to get that. It was just automatically gathered in the course of routine patient care. So it's designed for multiple purposes, and evaluation is one of the biggies.
Thank you, David. And this question touches on some of what you said. They're wondering how to use Continuum in creating service plans and how easy it is to create a service plan based on the report that Continuum generates.
Yes. Well, if you now can visually see which are the critical areas of need, and you can see which are the criteria of the DSM that are met, and you can see the imminent needs, and use that report to begin your treatment planning process, you're obviously getting everything digested and calculated and presented very cleanly to begin writing the treatment plan. We know that programs are interested in some additional derivative products, like an automated treatment planner. There is a mechanism that was based on the ASI that we will be able to adapt to Continuum. We haven't done it yet, but as soon as a program or a system or a county or state says, "Oh, we want that," we will be glad to cost that out and provide a quote for getting that product. And there may be EHR companies that have their own proprietary tool that may want to adapt that to Continuum as well. So I suspect within the year we'll start seeing those treatment planners emerge, and there may be multiple ones, so you'll actually get to choose the best for your needs.
And I see we're hitting the hour. Do you have a couple more minutes for a few more questions, David?
Sure.
We have a question. Does the non-substance use disorder diagnosis impression feature include other disorders besides anxiety and depression?
Yes, so it assesses anxiety, depression symptoms, thought disorder, cognitive impairment, hyperactivity, bipolar, PTSD symptoms, a broad range of psychiatric symptoms, OCD, and others. It doesn't generate the diagnosis, but it will definitely generate the symptom clusters and also access to issues, and it'll distinguish them from secondary or related to substance use or withdrawal versus an independent likely condition.
Thank you, and I'll pose one final question. I know there are some other questions out there, and I'll be following up after the webinar with those of you who did not get your questions answered, and feel free to email asamcriteria@asam.org if you want to get in touch with us. David, we have a question about what is the advantage to integration with an EHR, and will the product be offered as a standalone?
Oh, yeah, that's important. It's not being offered as a standalone. There are a whole bunch of reasons for that, but we are trying to comply with the federal initiative to bring all of modern medicine into the EHR environment. And that should include addiction medicine providers too. I know we haven't been thinking that way for many years, but it's time. Also, we are providing the EHR companies with a full description of all the fields, including the code, programming code for all the fields. It's called the API code. So when we give them that code, they are then equipped to integrate as much of the question and answers of Continuum into their EHR, which means your record. So if you want your EHR company to pull out either the final answers or the subscale answers or the full ASI and so forth, or all the questions and answers entirely into the EHR so that you and your other colleagues in your treatment program can go in and scan all the different issues that the patient has within the EHR, you'll be able to do that. ASAM will provide all of the code information to allow your EHR to do that. And that's a specification that was recommended by Harvard Business School in their study, and it was required by SAMHSA when they provided the support to create Continuum. So we want you to be able to use all of the strengths of the modern EHR, and they're evolving, so there'll be more strengths as time goes on for evaluation and patient care and so forth.
Thank you, David, and thank you everyone for hanging in with us past the hour. We'll be following up with you, and if you have any questions that you want to send to us, feel free to email asamcriteria@asam.org. Otherwise, those of you who submitted questions through the Q&A box with the GoToWebinar, I will be following up with those of you who we were not able to reach. Thank you very much.